Anxiety disorders and other related disorders. Anxiety is an emotional response to internal and external stimuli or stressors. Anxiety is necessary for survival, whereas stress is not. So, if you recall from our previous lecture, mild anxiety is healthy. It is a good level of anxiety. It helps to keep you focused and it makes you more productive. However, when anxiety is not controlled and it begins to progress to the latter stages, that's when it becomes crippling. When anxiety interferes with social, occupational, or other important areas of functioning, it is considered pathological and a disorder. Anxiety disorder is most common psychiatric illness and is more commonly seen in women. Anxiety is believed to run in families. Anxiety is a subjective emotional response. Anxiety and fear differs because fear is cognitively related, whereas anxiety is emotionally related. For many years, anxiety was classified as a physiological response. So they focused on the cardiovascular effects, racing heart rate, uncontrolled tremors and sweat. So it was thought to be physiological. However, there were other theorists that thought it would be psychological. So Freud was the first psychotherapist to associate anxiety with neuropathic behaviors. So research now shows that anxiety is both related to the mind as well as the body. So the mind is unable to control these thoughts, therefore, that affects the body's response. And the person starts to experience physiological symptoms. So, since we stated that anxiety is an internal or external stimuli, which you typically is a stressor, let's define what a stressor is. A stressor is considered an external pressure on an individual. Everyone deals with stress differently. So, what does anxiety look like? Physiological effects include the autonomic nervous system kicking in, which increases your heart rate and blood pressure and respiratory rate. You may also experience some psychomotor symptoms where you may have some trembling or shaking of your hands. You also may experience some cognitive effects, which may include um, loss of thought or inability to focus, unable to rationalize the situation or make a logical decision. So let's talk about the levels of anxiety. So for a mild level, these are some of the symptoms that you may see. Special attention, increased sensory stimulation, and it could be motivational. So mild anxiety can be healthy, especially when you're studying or you're trying to accomplish a very important task. It may help you to focus. So moderate anxiety, some of the symptoms include feeling something is definitely wrong, nervousness, agitation, difficulty concentrating, being able to be redirected at this stage. So someone can say, hey, you seem kind of nervous and help you to kind of regain control. Severe anxiety is trouble thinking and reasoning. Your muscles may become tense. Your vitals start to change. You may become restless, unable to sit still, could be irritable, and either even angry. And the fourth level, which is panic or panic attack, at this level, the patient or the person would feel the urge to fight, defend themselves, flight, as in fleeing the situation, or totally freeze and unable to respond appropriately at all. So, what happens is your body kicks into survival mode and adrenaline is released. So, your vital signs are increased at this moment. You have enlarged pupils, so that's another physical symptom that you could see in addition to your cognitive process focusing on defense. So you are not able to think and rationalize and think logically. You're focused on survival mode. So you are really just trying to meet the needs of whatever the situation is that you perceive is imminent danger. So the stages of reacting to stress. So we have three stages. So alarm reaction stage is preparation for defense. It sends adrenaline and norepinephrine to prepare for potential defense. Resistance stage. Blood is shunted to areas needed for defense, such as muscles to prepare for fight, flight, or defense. Exhaustion stage. So your stores of energy are depleted, your emotional components are unresolved, and this is when a person responds very negatively to anxiety. So they may just feel like they are in a a stupor or a kind of a depressed state. So the etiology or cause of anxiety, we have several theories. The biological theory includes genetic theories, neuroanatomical theory, biochemical theory, neurochemical theories. So the genetic theory, anxiety may have an inherited component because the first degree relatives of clients with increased anxiety have higher rates of developing anxiety. Then our neuroanatomical theory, pathological involvement of a specific area of the brain may be involved in these disorders. So for a panic disorder, it is stated that the temporal lobe has some type of pathological findings. And for anxiety disorders, the frontal cortex and the limbic system appear to be involved and have a pathological finding. Then we have our biochemical theory, which the increase in blood lactate occurs for patients diagnosed with panic disorder. And also, if an infusion of sodium lactate is given to a patient with anxiety neurosis, they will develop symptoms of panic disorder. So, this elevated blood lactate level will affect the person's anxiety levels. Neurochemical theory, that includes GABA levels as well as our serotonin levels. So GABA is known to reduce anxiety, whereas our norepinephrine, which is serotonin, increases anxiety. So research believes that the problem with regulating these neurotransmitters occur in anxiety disorders. So serotonin is believed to play a distinct role in OCD, panic disorder, and generalized anxiety disorder. An excess of norepinephrine is suspected in panic disorder, general anxiety, and post-traumatic stress disorder, or PSD. So we'll talk about those other diseases on our part 2 for this recording. Then we also have our psychodynamic theory, which includes the view of anxiety focus and the inability for the ego to intervene, causing conflict between the id and the superego. So if you look at the picture I have here on this particular slide, it is explaining our id, our superego, and our ego, because I don't think we've talked about that in our lecture. So for the id is our unconscious, so it's innate pleasures and desires, aggression, sexual impulses, all these things are stemmed from the id. The superego. The superego is our moral ethical values, right? So that's where we are consciously saying, oh, this is right, this is wrong, I should do this, I should not do that. And then the ego, the mature adaptive behavior presents itself. So this is how we present ourselves to the world. So there could be a struggle between our innate desire and our moral or ethical values. So when there is a struggle between these two, then the ego produces anxiety. So this is the psychodynamic theory, which is a theory that Freud is the founder of, Sigmund Freud. Then we have our cognitive theory, which is faulty, distorted, or counterproductive thinking patterns resulting in anxiety. So these particular patterns of thinking result in anxiety levels that are not managed and produce maladaptive behaviors or an emotional disorder. Etiology continued. Psychoanalytic theory is the unconscious fears that may be expressed in a symbolic manner as phobias. Then you have learning theory, which are fears that are conditioned responses and thus are learned by imposing reinforcements of certain behaviors. Temperament, characteristics in which one is born that influences how he or she responds throughout life to specific situations. For example, innate fears. Life experiences. Early experiences may set the stage for phobic reactions later in life. Let's talk about what a phobia is. A phobia is an illogical, intense, and persistent fear of a specific object or a social situation that causes extreme anxiety and interferes with normal functioning. Phobias may have a connection to negative past experiences. So here I have some types of anxiety. So agoraphobia, this anxiety is a fear of being unable to escape to safety. So oftentimes these individuals will isolate themselves or even barricade themselves in the house, and they will not come out and just do everyday activities such as work and school and shopping, and they are afraid. They feel like there's danger like all around them. Panic disorder. So these individuals will have like a feeling that he or she is dying. So this is considered a panic attack. And some symptoms include palpitations, sweating, tremors, shortness of breath, a sense of suffocation, chest pain, nausea, abdominal distress, dizziness, and the fight or flight or freeze response kicks in the panic disorder or in the midst of a panic attack. All right, so specific phobias. Specific phobias present as an intense, exaggerated, and persistent fear of a situation or object. Social anxiety disorder or social phobia is when a person fears doing something that will embarrass them or will cause others to negatively evaluate them. General anxiety disorder consists of worrying 50% of the time in the last 6 months or more. Then general anxiety disorder would be diagnosed. So that's abnormal to worry 50% of the time, and for that worrying period to last for 6 months or longer. Selective mutism is a diagnosis in children when they fail to speak in social situations, even though they are able to speak. Anxiety disorder due to medical conditions is diagnosed when the prominent symptom of anxiety is judged as a result of a direct physiological condition. And then we have substance medication induced anxiety, which is anxiety directly caused by drug abuse, medication, or exposure to a toxin. Separation anxiety disorder is an excess anxiety concerning separation from home or from persons, parents, or caregivers to whom the client is attached. Self-assessment, you're going to do a generalized body assessment as well as an assessment for their psychosocial status, for their anxiety. So your book has the Hamilton rating scale, which ranges from 14 to 30, mild, moderate to severe anxiety. You also want a history of the patient's behaviors or psychiatric history, even if it is family history, as well as look at their general appearance. Are they well groomed, disheveled? Do they have slow speech or rapid speech? Do they have slower than normal motor skills, or are they restless? Right? So you want to make sure you have a comprehensive idea of your patient. You want to also keep in mind that sometimes our psych patients will use blaming statements. They may feel like they're losing control. They may become confused or disorientated when they have a panic attack. They may have triggers, relationship triggers, so you want to be aware of those. You may often see problems sleeping or problems eating. So you want to be able to put all of this in your assessment so that you can relate this to your IDT team so that the patient can properly be cared for. You also want to note if the patient has disorganized thought, right? If they have incoherent speech, if they have a flat affect or mood. So you just want to make sure it's a comprehensive assessment. Nursing interventions. So, first, provide a safe environment for both the patient and the nurse. Make sure the patient has privacy, especially if they're escalating or having a panic attack. You want to focus on calming the patient down by incorporating or encouraging relaxation techniques, cognitive reconstructing techniques such as guided imagery, thinking of a good thought, thinking of their favorite place to help calm them down, or even deep breathing techniques. Engage the client to explore how to decrease stressors and anxiety provoking situations in the future. And also use a calm, reassuring voice when speaking with the client. So your textbook has sample care plans for problem statements related to the anxiety and OCD related conditions. So please read through the care plans. Also, it has a section for all of our nursing process um, categories for our mental health. So read through those as well so you're familiarized with a psychiatric care plan. So desired nursing outcomes. Your patient is to remain active in their treatment. Whether they're outpatient or inpatient, they should remain active in their treatment. After interventions, the patient will be able to recognize signs and symptoms of escalating behavior, right? So if they have anxiety, they'll recognize when they're starting to escalate to a panic level, or OCD, if their behavior starts to get out of control, they start to escalate, they will recognize those signs and symptoms. You want them to be able to maintain a manageable level of anxiety. Once again, anxiety is not all bad. Uncontrolled anxiety is bad, right? When we start to escalate to a panic attack, that's when it's an issue. However, mild anxiety is good, it keeps you focused. Verbalizing future plan of action for the responding in the presence of a phobia. So they want to be able to have a plan if they encounter a situation that they're uncomfortable with and it is their phobic situation, object, or situation, then they need to have a functional plan so that they are able to still maneuver in that particular circumstance. Demonstrate increasing adaptive coping skills and strategies related to dealing with their anxiety versus their ritualistic behaviors. So you want your patient to be able to say, this is how I will handle this situation. This is how I will deal with the repetitive behaviors. Here's another question for you. Is the following statement true or false? The neurotransmitter dopamine is associated with anxiety disorder. I'll give you guys a few seconds to answer this. And the answer is false. Neurotransmitter GABA and serotonin are thought to play a role in anxiety disorder, not dopamine. And that's all, folks. Lecture is complete.